Thank you very much. We've got a few minutes for some questions for either Paula or Yen. The floor is yours.
Yes, I'd like to put a question to Yen, actually. An absolutely fascinating talk about the proton machines. And so the sort of query I've got at the moment is if indeed we are carrying out a treatment of the protons on the basis that can't destroy matter but only changes state, what happens to the protons when they've carried out the destruction of the cancer cells?
So their energy dissipates, and the interesting thing is they produce electrons that we can actually pick up on a PET scan. So one of the very interesting things about proton radiotherapy is if you can get the patient into a PET scanner within 15 minutes of the protons being delivered, you could actually see whether the proton hit or your radiotherapy hit where you wanted it to hit, which isn't actually true of X-rays. We use surrogate markers of X-ray radiotherapy. So that's a very exciting part about proton radiotherapy, but that does require quite a lot of infrastructure in that you have to get your patient to the PET scanner within 15 minutes, otherwise those are disappeared.
Hello, yes. No, my question really, I hope I didn't miss the point, was the relative effectiveness of protons versus X-rays in actually what damage it does or does not do to human cells.
So you didn't miss the point at all. I didn't actually cover that, so that was very, very insightful of you. So the biological effect of protons are felt to be the same as X-rays. So it's what we call something. We have a measurement called the biological radiation equivalent, and in protons it's about 1.1 compared to X-rays. So when we think about dose and treating in grey, we use essentially the same grey or the same grey is used.
Question for Paula. You talked about research on the number of fractions from, say, 1 to 5 using treatment. I couldn't quite pick up whether you're also varying the intensity of the individual doses of those fractions and what effects that have.
And again, that's a very good and insightful question. If we're comparing one dose or one fraction of radiotherapy, the dose there is slightly bigger. For example, it's 10 gray as opposed to 17.5 gray, which would be given in 2 fractions. So it's 10 gray versus 2 doses of 8.5. That's the MRT lung trials. The biological equivalence, as Jens referred to, between those 2 doses is the 2 doses are probably much more active against the cancer, but potentially the effect on reducing the symptoms the cancer is causing appears to be the same. So although the intensity of having 2 doses is more dose of radiotherapy biologically, you actually get the same benefit from just using 1.
As long as it's a bit higher.
Yes. Exactly.
I have a question for Paula as well, who's sitting next to me. But my query was really to do with how you monitor the size of a tumour. There seems to be a reluctance to do X-ray microscopy or whatever the term you use, or X-ray imaging in combination with the radiography. So is there any other indirect measure of tumour size, such as an analytical test or whatever? Are progress in that area?
I think after lunch we'll probably go into detail about what we call image-guided radiotherapy. So we are routinely using images, so actually taking X-rays, either at CT scan versions of X-rays of a patient at the beginning of radiotherapy, potentially a week later, or a few treatments later, and making sure that we've got the beams aiming at the right place, and we can see where the cancer is. So we are actually using imaging to ensure that we're treating in the right place and that the cancer hasn't changed shapes significantly or hasn't moved. So we are actually using that. I didn't concentrate on that because from the palliative radiotherapy at present, the concentration until now has been, let's see what we can do with a relatively wide margin of fields so that we know we've covered it, and fewer doses for same benefit. But as the last years have shown, when we're looking at palliative radiotherapy, we actually do need to think of the new technologies to see if we can actually give a bigger dose to a smaller area and know we've got a cancer in us. We will be using image-guided radiotherapy for palliative as well, actually.
Thank you. Final question.
This is a question that can be addressed from the patient perspective and from professional expertise. I firstly to I'm conscious that you said that you think proton therapy is quite promising, and were you saying that it's promising on its own, or it will still be used with other treatments, chemotherapy and surgery?
So I think it's promising as a technology for radiation, or in that I still think it's not going to be the be-all and end-all, and for many tumours you need a combination of surgery and radiotherapy and chemotherapy, and for many paediatric tumours, in fact, all three. And I don't see proton radiotherapy necessarily replacing that. I just think it is another modality of radiation that can be used with a different side effect profile.
Just from the global perspective, because you are working internationally as well, bearing in mind that 70% of all cancers, the burden of cancer will be in the developing world, and many countries do not have radiotherapy machines, even in the Caribbean, they travel to other islands. Are there any plans to actually look at where treatments will be needed globally as well, and get any machines there?
So again, I think that from a radiation point of view, we need to think about what we can do for the for more people with the resource that you have. So actually putting a linear accelerator in is much more effective than putting a proton beam therapy machine in. So I think the first step is always to have good access to X-ray photon therapy, and then the second layer would be having good access to cutting-edge radiation therapy. And I think that is just the rather sad truth of having a limited amount of resource in the pot, unfortunately.
Thank you very much, and particular thanks to our last two speakers for two very good talks, very informative.